Thank you very much for the opportunity to present at this esteemed conference. My name is Juan Jimenez, Professor of Surgery at the University of California, Los Angeles.
The emergence of thermal ablation 2 decades ago provided a less invasive alternative to surgical saphenous vein ligation and stripping for the treatment of symptomatic, incompetent truncal veins. They have now become the gold standard for treatment of this condition. The most recent consensus practice guidelines from the Society for Vascular Surgery and the American Venous Forum recommend treatment with endovenous ablation over high ligation and stripping of the great saphenous vein because of less post-procedure pain and morbidity and an earlier return to regular activity. The introduction of commercially manufactured 1% polidocanol microfoam, also known as Varithena, provides another minimally invasive option for the treatment of saphenous and tributary vein reflux. Like thermal ablation, it can be performed under local anesthesia in the ambulatory setting. Polidocanol works as a non-ionic surfactant sclerosing agent. It attaches to the lipid cell membrane of the venous endothelium, resulting in the disruption of the osmotic barrier and damage to the endothelium with resultant vasospasm. The endothelial destruction leads to thrombus formation and occlusion of the venous lumen. Microphone ablation does not require tumescent anesthesia, and there is no risk of thermal injury to the saphenous nerve because the mechanism does not involve heat. Both procedures can be performed using solely local anesthesia with or without oral sedation. Radiofrequency ablation has been used safely for over 20 years and is the current gold standard for saphenous vein closure, with good safety and outcomes supported by level 1 evidence. Injection of perivenous tumescent anesthesia is not required for microfoam ablation, and there's no risk of heat-induced nerve injury. A wide variety of vein diameters and tortuous anatomy can also be treated. A retrospective review of a prospectively maintained patient database was performed from procedures in our ambulatory procedure unit, also known as our APU. Our APU is affiliated with a large metropolitan tertiary care academic medical center at UCLA. All patients who underwent RFA and MFA for symptomatic truncal and tributary vein reflux between June 2018 and September 2022 were identified. Symptomatic patients were defined as those who presented with associated lifestyle-limiting physical signs and symptoms. These include, but are not limited to, pain, aching, heaviness, fatigue, edema, venous stasis changes, and both active and healed ulceration. Duplex ultrasound evidence of reflux greater to or equal than 0.5 seconds occurring caudal to the saphenofemoral junction in the upright position was required for study inclusion. Prior to either RFA or MFA, all patients had failed conservative therapy with at least 6 weeks of compression therapy. All patients with venous ulcers were treated concurrently in our wound care center and were compliant with weekly dressing changes, offloading, nutritional counseling, and compression. Patients who underwent either RFA or MFA for symptomatic reflux in thigh, great, and accessory saphenous veins were included in the study. All RFA and MFA procedures were performed under local anesthesia with or without oral sedation. Patients treated for concomitant tributary veins with either tributary vein sclerotherapy or stab phlebectomy were excluded from this cohort. Preoperative variables reviewed included demographics, body mass index, history of deep venous thrombosis, hypercoagulable disorders, oral anticoagulation therapy, and baseline SEEP clinical class and venous clinical severity scores. Procedural details, including specific truncal veins treated, truncal vein diameters, and operative times were analyzed. All patients in the study had a postoperative duplex scan at 48 to 72 hours post-procedure to assess for target vein closure and DVT. Patients were instructed to wear 20 to 30 millimeter thigh-high compression stockings continuously for 14 days after their procedure. Postoperative outcomes analyzed included vein closure, symptomatic improvement, VCSS, ulcer healing rates, thrombotic and non-thrombotic complications. 200 consecutive thigh, great, and accessory saphenous veins were treated within the study period with either MFA or RFA. Deep venous reflux was present in most patients in both groups, 7 limbs in the RFA group and 11 limbs in the MFA group had active venous ulcers at the time of truncal vein closure. In the RFA cohort, 98 great saphenous veins and 2 accessory saphenous veins were treated. In the MFA group, 83 great saphenous veins and 17 accessory saphenous veins were treated. The mean maximal truncal diameters in the RFA and MFA groups were 7.6 and 8.7 millimeters respectively. No limb in either cohort underwent concomitant stab phlebectomies. The total mean operative time in the RFA group was 42.4 minutes versus 33.8 minutes in the MFA group. This was statistically significant. The mean volume of microfoam used per treatment was 6.1 milliliters. Complete truncal vein closure was achieved in 100 limbs following RFA and 90 after MFA. 8 veins in the MFA group partially occluded and 2 remained patent following treatment. The 2 patients whose limbs remained patent following microfoam ablation had body mass indices of 38.7 and 37.5 respectively, and also vein diameters of 9.7 millimeters and 29 millimeters respectively. Both patients were also on chronic oral anticoagulation at the time of their procedure. The remainder of anticoagulated microfoam limbs demonstrated complete closure. All patients on oral anticoagulation at the time of their radiofrequency ablation procedures completely occluded. 15 limbs in the RFA and MFA groups required subsequent venous procedures to address residual symptoms. Rates of adverse thrombotic events did not differ significantly, but did trend higher in the microfoam ablation group. All were asymptomatic and resolved without clinical progression with oral anticoagulation. No symptomatic DVT or pulmonary emboli occurred in either group. The incidence of ablation-related thrombus extension was 1% and 4% following RFA and MFA respectively. This difference was not statistically significant. 2 remote DVTs occurred following microfoam ablation. All were asymptomatic and resolved with oral coagulation with apixaban following 18 days in 1 RFA patient and a median of 26 days in the MFA group. No cardiovascular or neurologic complications were noted in the study. 7 patients in the RFA group and 14 patients in the MFA group reported localized pain at their 3 to 6 week follow-up visit. Superficial thrombophlebitis was noted following RFA in 6 limbs and after MFA in 15 limbs. Complete ulcer healing rates in the RFA and MFA groups were 86% and 73% respectively following treatment. The complete ulcer healing rates for the entire cohort was 77.8% during the study period. No skin burns, new onset ulceration, or paresthesias were noted in either group. The mean venous clinical severity score decreased to 7.3 and 7.8 in the RFA groups from their preoperative values of 9.4 and 9.9 respectively. Symptomatic improvement was reported at last follow-up in 90% following RFA and 89% following microfoam ablation, with 89.5% of patients in the entire study cohort reporting symptomatic improvement. Limitations of our study include a non-randomized and retrospective design. Because we do not perform routine ultrasound surveillance after the initial post-procedure scan in asymptomatic patients, data regarding long-term durability of vein closure following microfoam ablation was not obtained. We also did not utilize a quality of life assessment, a survey, which may further expand the description of the patient's symptomatic improvement following both techniques. Both RFA and MFA result in excellent early symptomatic improvement and ulcer healing rates following treatment of symptomatic reflux in superficial truncal veins of the thigh. These favorable outcomes were noted in both groups despite higher complete occlusion rates following RFA. Operative times were shorter in the MFA group. The incidence of ablation-related thrombus extension was low in both groups, and both modalities are safe for saphenous vein closure using early post-procedure duplex ultrasound surveillance and selective anticoagulation. Prospective studies with long-term follow-up imaging are required to assess durability of MFA for this clinical indication. Thank you very much.